Hola, buenos días a todos. Es para mí un honor presentarles en esta ocasión al doctor William Benitz. Él va a estar con nosotros con el tema de nuevos enfoques para la determinación de sepsis neonatal, él en el inicio temprano. Es muy importante para todos nosotros, tanto pediatras como neonatólogos, así como enfermeras que acuden a nuestras reuniones. Esta es la reunión número 71 de la federación, donde semana tras semana hacemos estas pláticas para ustedes y espero su gran aporte académico para su práctica clínica diaria. Le damos la bienvenida al doctor William Benitz. Él es profesor emérito de la Universidad de Stanford. Tiene numerosas publicaciones, así como numerosos cargos como jefaturas de hospitales prestigiados de la neonatología. Él nos va a abordar el día de hoy el tema de New Approaches to Ascertainment of Early Onset Neonatal Sepsis. Bienvenido, doctor.
Very good. Thank you, Dr. Romo, for that warm introduction. It's a great pleasure to be here. I hope that everyone can hear what I'm saying and see my screen. I would like to begin by noting that I have no financial relationships or conflicts of interest to disclose, and I won't be discussing any off-label or experimental or investigational drugs or devices in the remainder of this talk. Here are some objectives for the talk. I'm not going to spend time reading through these, but hopefully we will achieve these over the next few minutes. I'd like to start by pointing out that the topic for today is not about which ancillary diagnostic test to use, how to do the blood cultures, or which new molecular test for bacteremia, or whether to perform a lumbar puncture in evaluation of infants for early onset neonatal sepsis. Rather, I'd like to focus on some more fundamental issues that I've found it necessary to give a great deal of thought to over the last 4 or 5 years. And I hope that by reviewing my thought process, I can give you all some ideas about how you might approach the evolution of your own practice, as my practice and that of my colleague at Stanford has had to evolve. The question that I'd like to address today is really a fundamental question, and that is, which babies qualify for evaluation in the first place? Where do we start? How do we get our mind around this question of how we can prevent babies from the catastrophe of early onset neonatal sepsis? And the short answer for this is that all newborn babies need evaluations for signs of sepsis, but that only those who are showing signs that they are sick need additional diagnostic testing and antibiotic treatment. And I'll try to show you the rationale behind both of these conclusions over the next few minutes. Before I get on to that, though, I'd like to say a word about prevention of neonatal infections. I'm going to present some ideas that are somewhat iconoclastic and represent some fundamental changes from the approaches that I learned when I was in training and which I practiced for the majority of my career. Because I will be advocating doing less in the way of investigation and intervention for these babies, I want to be sure that I don't create confusion. And I certainly don't want to suggest that we should stop doing the things that have created the changes that have made adaptation of our approach to ascertainment of neonatal sepsis necessary. The Group B Streptococcus prophylactic strategy reduces early onset sepsis, not just Group B strep sepsis, by greater than 70%. Treatment of mothers with chorioamnionitis with interpartum antibiotics prevents early onset sepsis and reduces its rate by greater than 80%. Latency antibiotics for preterm premature rupture of membranes reduces early onset sepsis by about 35%. And it makes sense actually that this would be less effective than the other treatments that I just noted, because preterm premature rupture of membranes is often a consequence of the fact that the baby is already infected, and the rupture of membranes occurs as a result of that disease, not as the cause for it. So it makes sense that treatment with antibiotics will not be able to prevent something that is already well in process. And finally, the CLABSI, or central line associated bloodstream infection bundle, which all of our units have adopted over the last few years, reduces late onset sepsis by greater than 70%. All of these interventions work, and we have to keep doing them. And in fact, we need to redevote ourselves to doing them well. And I'll show you data that documents that, in fact, we have been doing them well along with our obstetrical colleagues. But why do we worry about this? I don't think it will come as a surprise to anyone in this audience that exposure rates to antibiotics in the babies who come under our care is extraordinarily high. If we look at the top of the slide, the early extremely low birth weight babies and very low birth weight babies who come into our NICU are almost always exposed to antibiotics. In this study by Cotton from 2009, more than 90% were exposed to antibiotics. As we move down the slide to very low birth weight babies who don't have early onset sepsis or necrotizing enterocolitis, the exposure rate, even in these babies who do not have infection, is over 80%. NICU babies overall, 75% in this study, and about 70% in this other report. And in many of these cases, these babies are treated for long periods of time, more than 5 days, more than 4 days, more than 4 days, more than 5 days, and more than 3 days. So our NICU babies are exposed to antibiotics very frequently and often for extended periods. But if you look at the babies who are near term or term, babies that are greater than 34 or 35 weeks gestations, we can see that the exposure rates in these much lower risk babies are also quite substantial. This data from a paper by Josie is from my own institution, and it shows that our baseline exposure rate to antibiotics for our low-risk babies in our transitional care and well baby nursery were exposed to antibiotics in 12% of the cases. That is 1 in 8 of these late preterm or term babies born at our institution received antibiotic treatment. In this data from Australia, 14% were exposed. And in this data, looking at only babies who appeared to be well, in the Boston hospital systems, 8% of these apparently well babies were exposed to antibiotics. So we're giving a lot of antibiotics to babies who are at very low risk. I'm not going to spend time going through the adverse impacts of antibiotics, but we'll just stipulate at this point in the talk that unnecessary antibiotic exposure is not a good thing. But what's the siren song of antibiotics? Why do we do this? Treatment of newborn infants with antibiotics has a number of effects that we find desirable. It may prevent colonization or progression to invasive disease. It may prevent complications or sequelae of infection once it's established, and it may reduce mortality from serious bacterial infection. And of course, that's the primary goal that we all hope to achieve. However, I would like to quote these words of wisdom from my friends Sagari Mukopade and Karen Popolo, who work at Pennsylvania Hospital in Philadelphia as part of the Children's Hospital of Philadelphia system, where they state quite wisely that antibiotics, like all medications, have risks and benefits. If not infected, the infant can only assume the risks. And another way to say that is if the baby doesn't have an infection, there can't possibly be any benefit from antibiotic exposure, and they're left with only the risk exposure from that. Well, our legacy strategy for neonatal sepsis, as I mentioned, what I grew up with, really consisted of the philosophy of treat early and treat often. Back in the 1970s and 1980s, when I was a young physician, neonatal sepsis often presented with a catastrophic presentation of a baby presenting in a fulminant septic shock, respiratory failure, and an intractable decompensation from which we could not rescue them. And we were appropriately alarmed by that. And unfortunately, it was a very common event. In our nursery, we would see a seriously affected baby like that on the order of every month or two. In about 2015, though, it began to feel uncomfortable to me that we were still so aggressive in approaching these babies, because it just didn't seem like we were seeing cases like that any longer. And I began to ask the question of, have we been wrong all these years in overtreating? And I think that the answer to that question is clearly no. What we were confronted with back in the 1970s and early 1980s, actually through the 1980s, was a very different circumstance than what we are confronted with now. On the other hand, is the old way still correct? I think the answer to that question is also emphatically no. And what changed? Why was something that was correct years ago no longer correct now? The first item is that there is a much lower secular rate of early onset sepsis in the population that we serve at this point. 30 years ago, the secular rate of early onset sepsis was on the order of 5 per 1,000 live births. More recently, it's been on the order of 0.5 thousand per 1,000 live births, a decrease of about 10-fold. Second, there has been better data that allows us to further stratify risk in preterm versus term infants and well-appearing versus ill-appearing babies. And finally, there's a much improved recognition and appreciation of a strong relationship between gestational age and chorioamnionitis and the risk of early onset sepsis. And I'll review data related to all of those now. Well, after I wrote a paper in 2015 with James Wynn, who's now in Florida, and Dr. Poland of the physiology textbook, who is at Columbia, of course, and well known, I think, to all of you, where we made the statement, which I actually wrote, that the rate of early onset sepsis had declined by about 10-fold between the 1970s and 80s and current time. When I saw that in print, I looked at it and I thought, I wonder if that's really true. I better pull the data and see if that's the case. So I spent several days actually finding all of the papers that I could that provided population-based data on the early onset sepsis attack rate in newborn babies, beginning from 1975 and extending up at that point to about 2015. And as of last week now extended out to 2020. And whether we consider early onset sepsis to be that happens in less than 2, 3, 6, or 7 days, in the colored dots here, we can see that the rate of early onset sepsis is quite variable in these early days, ranging from, in some cases, as low as 2 to some cases as high as 7, but around 3, 4, 5 cases per 1,000 live births up until about 2000. And between 95 and 2000, the rate of sepsis began to decline. And by 2005 was down to less than 2 per 1,000. And by 2010, less than 1 per 1,000. If we look at some very recent data from Norway, going from 2010 to 2020, so essentially over the last decade for babies who are greater than 34 weeks gestation, we can see the rate in this population of more mature babies, excluding the high-risk preterms, that the attack rate is now down to less than 0.5 per 1,000. So the assertion that I had made without first gathering the data turns out to be correct, and I'm relieved to say that this is true, and pleased to point out that we have made such enormous progress in managing this. Well, how did we achieve that? Well, one of the things that we did was we adopted strategies for prevention of early onset root B streptococcal sepsis. This began with release of statements by the American College of Obstetrics and Gynecology and the American Academy of Pediatrics in 1992. These statements were inconsistent with one another and created some tension between the two societies. And that led to the convening of a consensus conference, which released draft guidelines in 1995 that were published fully in their final form in 1996. But as this discussion was taking place, the processes that were recommended were already being implemented, and the rate of early onset group B strep, shown in the dark red line here, was already decreasing. And by the year 2000, it had reached almost 0.5 per thousand, and it has continued to decrease over time and is now at about 0.2 to 0.25 per thousand live births, a remarkable reduction and one that has been very nicely sustained. There's been a small but less impressive but statistically significant decrease in late onset sepsis as these guidelines have been adopted and implemented into our practice. I would point out at this point that this achievement is to be credited to our obstetrical colleagues. This is not something that we did as pediatricians or neonatologists. We certainly had a role in helping the obstetrical community plan these interventions, but they're the ones that are doing the heavy lifting. And I think we are enormously indebted to them for the successes that they have achieved in reducing the rates of early onset GBS disease in our patients. There's similar data showing a comparable decrease in the rates of Listeria infection over the same time period. And I've marked on this graph showing the cases per 10,000 admissions to the NICU against time from 1990 up to 2015, showing the implementation of guidelines for group B strep prevention. And you could conclude from this that the GBS prevention guidelines actually had a lot to do with this. Perhaps they did, but I think more importantly, what has happened over this time interval is that our obstetrical colleagues have become more and more aggressive at advising pregnant women on strategies for avoiding exposure to unpasteurized dairy products. And I can testify from the experience with my own daughters as they were pregnant with my grandchildren, who now range from 3 weeks to 8 years of age, that their obstetricians advised them very strongly to be very careful about unpasteurized dairy product exposures. And it's those public health measures, again, implemented by our obstetrical colleagues, that have resulted in this marked improvement in the prevalence of Listeria, to the extent that it has now virtually disappeared and is very, very rarely seen in the United States as a cause of neonatal sepsis. Well, given that background with those changes, it became very apparent, as I say, by about 2015, 2016, that major revision in the recommendations for management of these babies was necessary. And at that time, I happened to be a member of the Committee on Fetus and Newborn of the American Academy of Pediatrics, and I was assigned, along with Karen Popolo, to co-author in collaboration with the Committee on Infectious Disease revised guidelines for management of babies at risk for early onset sepsis. Those guidelines were divided ultimately into guidelines for treatment of preterm babies and separate guidelines for treatment of late preterm and term babies. And I'm only going to be talking about the latter category today. What we ended up recommending was three different approaches. And I have to give Dr. Popolo credit for coming up with the idea of categorizing it this way. The first approach is categorical risk-based thresholds, which are essentially the prior Centers for Disease Control, or AAP, guidelines. The second is an approach based on quantitative risk-based estimation, as represented by the sepsis risk calculator. It's produced by the Kaiser healthcare system in Northern California, in which Dr. Popolo had a major role in developing. And the third approach is real-time assessment of illness based on serial physical examination or close clinical monitoring. And I'll now walk you through the implementation and consequences of implementation of each of these three approaches. This is a slide showing the same information, taking a figure from the 2019 statement from the American Academy of Pediatrics on the management of the babies after implementation of interpartum strategies for prevention of group B strep. This shows in the first panel categorical risk assessment. This is the traditional AAP CDC guidelines, last updated in 2010. The middle panel shows a bit of a screenshot from the Kaiser Sepsis calculator showing how the data is entered. It doesn't show the flow diagram. I'll show you that in just a moment. And the third shows an option for enhanced observation. And I will point out that this is just one construction of enhanced observation. In this version of it, which is in the AAP statement, if the baby does not show signs of clinical illness, then maternal risk factors are considered. And if those are present, the baby is assigned to serial physical examination and vital signs for the first 36 to 48 hours, and diagnostic evaluation and treatment only if signs of illness develop. But if none of these are present, there's routine newborn care. I will show you an alternative approach to this that we've adopted at Stanford in a few moments. In the enhanced observation category, though, the key point here is that babies who are sick get treated. If they become sick, they get treated. It is the baby's behavior and not maternal risk factors that drive the decision-making process. Well, how did this all play out over the years? Let's go back to the mid-1990s when these CDC guidelines came out and look at what the recommendations were. If a mom had received interpartum prophylaxis for group B strep and the baby looked sick, then the recommendation was that the baby should have a full diagnostic evaluation and empiric therapy. And this is kind of the easy case. If the baby was not ill appearing, but they were less than 35 weeks gestation, all of these preterm babies got full diagnostic evaluation and empiric therapy. And actually, this was such a sweeping recommendation that implementation of this was far from perfect, because many practitioners really thought that that was much too aggressive and resulted in a great deal of unnecessary treatment. Well, as those practices were implemented and brought into routine use, data began to become available that told us how things were working. And there are two key reports, I think, one from California and one from Maryland, about 20,000 infants in each group. The California study, they looked at babies that were greater than 2,000 grams. They excluded babies with anomalies. In the Maryland study, they looked at babies that were greater than 35 weeks. So these would be nominally low risk, late preterm or term babies. In California, about 15% of the babies were evaluated for sepsis and nearly 5% were treated. In Maryland, about 10% were evaluated and about 2% were treated. In California, there were 26 cases of culture-proven early onset sepsis among these 18,000 babies for an attack rate of about 1.5 per thousand. And that resulted in a number needed to treat 855 divided by 26 of 39 infants treated for every one who had infection. Numbers in Maryland were a lower rate of culture-proven sepsis and a lower rate of treatment, but also a number needed to treat of nearly 40 babies who received antibiotics for everyone who was infected. And my friend and colleague, Dr. Escobar, who's the director of research for the Northern California Kaiser system, made very impassioned pleas at this point in time that treating 40 babies for everyone who was infected was really excessive antibiotic exposure, unnecessary, and needed to be brought to a halt. I had always said that I'm perfectly happy to treat 20 or 30 babies to prevent that one case of baby who's going to have fulminant septic shock and die. And I would stand by that number, but I even at that point agreed with Dr. Escobar that treating 40 was probably too many. In response to that and some other concerns, the guidelines were revised in 2002, and the major change in the management of the baby was the gestational age less than 35 weeks was no longer considered a cause for full diagnostic evaluation, but was an indication for limited evaluation and close observation for greater than 48 hours. However, there was an addition at that point of a new criteria for treatment, full diagnostic evaluation and empiric therapy, and that was that any baby whose mother received antibiotics for suspected chorioamnionitis was swept into this full diagnostic evaluation category. It's curious that the wording of this is that it's the receipt of antibiotics that is the risk indicator and not the presence of chorioamnionitis, but that is in fact how the guidelines came out. Now, this addition may actually be my fault, and I'm here to say mea culpa about that, and I'll come back to that in just a moment. But first, let's take a look at what the impact of implementation of those guidelines were as we move into the 2000s. And again, there are two key reports on this, one from Massachusetts and one from Pennsylvania. 8,000 patients in the first, 12,000 in the second. These are greater than 35-week gestation babies. In Massachusetts, 15% of the babies who appeared well were still evaluated for sepsis. They did a little bit better in Pennsylvania. This report, they looked exclusively at the babies who were exposed to chorioamnionitis, and they found that about 5% of their population was. And because of the recommendation to treat them all for chorioamnionitis, they were in fact treated. There were 4 cases of culture-proven sepsis among those 554 babies, for a number needed to treat now of 139. If we look at the broader population represented by the data from Massachusetts, there were 588 babies, or about 8% of the total birth cohort, were treated for sepsis. There were 3 cases of culture-proven sepsis, and the number needed to treat here is now nearly 200. Well, what's gone awry here? Why has the number needed to treat gone up so much? It's not that we're treating babies so much more. We're still treating about 15% of the entire birth cohort. But the key here is that things that are being done to prevent infection of the babies are actually infected. They're effective, so that the rate of EOS has gone down substantially from about 1.5 per thousand to about 0.4 per thousand. So we've got now a 75 or 80% reduction in the attack rate, and that results in a much higher number needed to treat. So this number looks like we're going in the right direction, but fewer cases of culture-proven sepsis is definitely the goal that we're trying to proceed. So let me just take a moment to talk about where this fear of chorioamnionitis came from. And I worry a lot that I may be largely responsible for this in a paper that I wrote along with my colleagues, Dr. Gould and Dr. Drusen, as part of a series of 3 papers on GBS prevention that we published in 1999 in pediatrics. In the course of putting that paper together, we identified 50 cases of infants who had early onset sepsis despite interpartum antibiotic prophylaxis that should have been effective in preventing infection in the babies. And of those 50 babies who had breakthrough infection despite appropriate interpartum antibiotic treatment, 44 had a history of exposure to maternal chorioamnionitis. So what we observed from that was that the probability of chorioamnionitis being present in a baby who had early onset sepsis despite appropriate preventive treatment was 0.88 or 88%. And from that, we made the observation that these observations suggest that chorioamnionitis is a marker of high risk for invasive GBS disease, even in infants whose mothers receive antibiotic prophylaxis. The problem with this is that I got the conditional probability here exactly backwards. I'm not really interested in the probability of chorio once the baby's already infected, and I know that. I'm interested in the probability that a baby will become infected if all I know is that the mother has signs of chorioamnionitis. So let's take a look at what the data says about this. First, in data from the NICHD Neonatal Research Network, we can look at the risk of early onset sepsis, cases per 1,000 births, as a function of birth weight, and we can divide that into the babies who had no chorioamnionitis exposure and those who did. The dark red showing the babies who did have exposure. In babies under 1,500 grams, about 80% of the cases of early onset sepsis are associated with chorioamnionitis exposure. About 2/3 in babies between 1,500 and 2,500 grams, but less than 1/3 of the babies over 2,500 grams. So although the rate of infection per 1,000 births is low here, the number of babies who are born at full term is so much larger. This group accounts for a very large proportion of the number of cases of sepsis, that is taking place in a population where chorioamnionitis is present in well under half, probably under 1/3. If we look at the relationship between early onset sepsis and exposure to chorioamnionitis, however, we see that there's a very strong relationship between the gestational age of the infants in questions and the risk of early onset disease. In babies who are late preterm or term, shown in the orange bars here, the probability of early onset sepsis, even with exposure to chorioamnionitis, is very, very low, shown as these very tiny bars here. This one's not missing, it's just so small that it's invisible. But when we're dealing with preterm babies, the more preterm the baby is, the higher the risk of sepsis in association with chorioamnionitis becomes. We can look at that same data from the Neonatal Research Network by organism, and I put this in just to remind everyone that in these extremely low birth weight babies, the vast majority of the cases are E. coli with a smaller proportion GBS. So E. coli is the dominant infective organism here, whereas when we're looking at the full-term babies, E. coli represents a very small fraction of the cases, and it's predominantly group B strep. And here's some additional data showing the relationship between gestational age and the early onset sepsis attack rate. As the babies become less mature, the probability of sepsis is much greater. Here, 15 or 16% of the babies in this data from Italy who were born at 23 to 24 weeks gestation had early onset sepsis. The majority of these babies who were born at 23 to 26 weeks gestation were born because of maternal chorioamnionitis. So this relationship between prematurity, especially extreme prematurity, and chorioamnionitis and the association with a high risk of sepsis is very much gestational age dependent. If we look at the early onset sepsis attack rate in babies greater than 37, 36, or 35 weeks in these various studies that have come to publication over the last 10 years, we can see that the attack rates are very low across the board, well under 1 per thousand in these populations of more mature babies. If we look at the data from Escobar, babies greater than 34 weeks gestation, less than 1 per thousand overall. This is about 0.7 per thousand in the overall population here. But what Dr. Escobar was further able to do was to divide the population into babies who had clinical signs of illness from those who did have clinical signs, shown in the dark red, from those who did not. And what he found was that the risk of sepsis was 20 times greater in the babies who had clinical signs of illness than it was in the babies who appeared to be well. We'll talk about how they use that data further in just a moment. So that's the background for the categorical risk assessment. We're seeing a lot of babies who are exposed to antibiotics using these criteria. The strategy is, however, effective at reducing the consequences of early onset sepsis, and it is successful in ascertaining the babies who do need to be treated. The multivariate risk assessment is shown here in this panel, and I'm not going to walk you through this beyond saying that this approach is by far the most complicated, and it's not an accident that it really is much more easily taken care of by plugging the data into a computer and letting a computer work its way through the algorithm and giving you the result and telling you what to do. The third option is the serial examination approach, and I will just point out that here, if there are clinical signs of illness at birth, evaluate and treat. If the baby develops signs, evaluate and treat. And if the baby doesn't develop signs, continue observation until discharge. And I'll show you our experience with that at Stanford over the last few years. Well, that second approach is based on the sepsis risk calculator that came from the Northern California Kaiser system. And this was really developed stepwise in 3 key papers. The first, authored by Karen Popolo in Philadelphia. Second, the first author is Dr. Escobar, who I've also mentioned at Northern California Kaiser. And the third, Michael Kuznowitz, also at Northern California Kaiser. In the first step, they developed a logistic model using risk factors to make individualized quantitative estimates of early onset sepsis risk. In the second step, they added categorical physical examination findings to stratify those risks further. And in the third, they provided an online tool that allows changing secular attack rates, incorporating exam findings and setting different evaluation and treatment thresholds. So here's how they went about doing that. In the first paper, Puopolo and colleagues, using a very large data set of over 600,000 babies, including 350 cases of early onset sepsis, they looked first at the traditional risk factors for early onset sepsis, maternal fever, prolonged rupture of membranes, or risk factors in combination. And they found that those traditional risk factors, as we suspected from actual experience with the CDC AAP guidelines, were not very sensitive. Temperature greater than 38 identified only 30% of the cases, greater than 39, only 7% of the cases. And in combination, they identified only less than 50% of the cases, but identified nearly 17% of the population. So about 1 in 6 babies were identified as candidates for at least evaluation, if not treatment. With the risk calculator, however, they found that depending on the threshold, and I'm just going to focus on the lowest threshold here, the risk calculator probability, and at this point, this does not include consideration of any physical examination findings in the baby. But if it was greater than 0.4 per thousand, given the maternal risk factors, that would identify 9% of the population that included about 50% of the cases, but half of the cases were not recognized by the calculator at this stage in its development. Because of that, the group of people who were working on this in the Northern California Kaiser system did some brainstorming, and they had the brilliant idea of saying, we should just look at the baby. So what they did was they stratified the prior risk probability based on the maternal risk factors that were put into the risk calculator into 3 different levels using a recursive partitioning model to establish what these thresholds should be. And then they further categorized the babies in each of these risk groups as well-appearing, equivocal, or clinically ill. And they came up with a matrix that looks like this, where the prior probability of sepsis and the number needed to treat are shown in each cell. These cells are combined because the number of cases in these cells was too small to provide statistically significant data. But once they had stratified the data in this way, they essentially said, what would happen if we treated all the babies where the number needed to treat was less than 200, and we decided to assess if the number needed to assess was less than 1,000? And the color coding here can appear on the next slide. If the babies are clustered this way, we can see that 85% of the population is assigned to observation. That includes 16% of the cases, so still a significant residuum. But the number needed to treat here would be nearly 10,000 for every culture-proven case of sepsis. 11% of the population was designated for evaluation, included about 1/4 of all cases. Only 4% of the population was identified for treatment, so this is fairly efficient in terms of being focused, but it only included 61% of the cases of early onset sepsis. So the problem at this point was that only 60% of the cases were identified, so nearly 40% are not identified, but 15% of the population still undergoes some evaluation or treatment. So some mechanism for identifying these 40% of babies who are not recognized is still required. And at this point, Kuznowitz and colleagues, as reflected in that 3rd paper, said, well, we're going to have to continue to monitor these babies. And if you read Kuznowitz's papers carefully, you will see that the Kaiser system has adopted a process for careful observation of all of the babies in their well baby maternity and postpartum environments for the development of clinical signs of illness. And in fact, their staff are quite good at picking those up, and those 40% of babies who are not initially recognized are ultimately recognized and receive appropriate treatment, and their outcomes are quite good. If we look at the antibiotic utilization after initial adoption of this strategy within the Kaiser system, we can see that in the baseline and learning periods, 2010 to 2014, in that Kaiser system, and remember that the Kaiser system represents a population of people whose health insurance is obtained through employment. So this is a relatively affluent, low-risk group. and they were treating about 5% of all babies born within the Kaiser system with antibiotics during the first 24 hours. With the adoption of the calculator-based approach, they were able to reduce that exposure from 5% to 2.6%. And they found that that was achieved without an increase in any adverse clinical outcomes, including need for inotropic treatment, ventilation, development of meningitis, death, or readmission to the hospital after discharge. So this is quite a nice achievement, a reduction of antibiotic exposure by 50% with adoption of that approach. Well, as that data was becoming available, my friend and colleague, someone who I met through sharing an interest in this work, Nick Ogden and I, were both interested in the question of, all right, so we've got a sepsis calculator and we can plug the numbers in and we get recommendations out, but what within the machinery of the calculator leads to decisions about clinical management for these babies? So we searched the literature and we identified 234 cases reported in the literature of culture-proven early onset sepsis for which there was sufficiently granular data on a patient-by-patient basis to calculate the risk score as estimated by the Kaiser risk calculator. We recalculated all of those values to use standard secular attack rates in the calculator. And we found that of the 234 babies, 84 of them were ill appearing at birth. And these essentially were the easy cases because the calculator says that even if the risk is less than 3, you should strongly consider treatment. If it's greater than 3, of course, we should treat. But essentially all of these babies, all 84, end up with a treatment recommendation. I think we all know that if someone tells any of us strongly consider treatment, we're going to go ahead and do that. So about a third of the babies were already ill appearing at birth and were the easy case. We just go ahead and treat them because they look sick. About 2/3 of the babies did not appear. They were well or equivocal at birth. And the key question for the utility of the calculator is how many of those babies were identified as being at high risk and therefore candidates for immediate early treatment. And it turns out that only 10% of those babies had a risk score that was greater than 3 after adjustment for the baby's physical examination findings. So the other 90% of these babies were put into either evaluation with a blood culture and periodic vital signs or more frequent vital signs with a low estimate of risk. But 2/3 of the babies were assigned to routine vital signs because they had neither maternal indicators of risk nor clinical findings suggesting risk. And yet those babies developed early onset sepsis and did require treatment. Now, the majority of those babies presented because they had signs of clinical illness. And if we look at the babies in this category, a total of 82 of the 117 cases for which we had sufficient data were not ill at birth, but did develop clinical signs. So we can rely on the babies to show signs of illness. So the upshot of all of this is that the important part of the calculator is what the baby's physical examination findings are at birth and how they evolve over time. And it's very important to be sure that you have a strategy for continuing to monitor these babies over the first day or two after birth. Well, how long do you have to monitor them? This graph shows the age and onset of clinical signs of illness. And as you can see here, almost all of the cases in which the babies became clinically ill did so within the first 48 hours. The vast majority within the first 24 hours. So 24 to 48 hours of observation is going to be sufficient to pick up the babies who show signs of clinical illness. What's also shown here is how the calculator risk estimate overlays on this. And you can see that babies where the calculator estimates a risk greater than 3, and these are the ones that would be identified for immediate treatment, are almost all clinically ill at the time of birth. So it's very easy to identify these babies. They're sick appearing and they need treatment, and you actually don't have to crunch the numbers to see what their risk score is. On the other hand, the babies who present with clinical signs of illness tend to have very low risk scores, and they're not easy to identify based on the presence of maternal risk factors. We can also look at this relationship as a function of whether mom received interpartum antibiotic prophylaxis. And I have to give credit to my friend in Italy, Alberto Berardi, for this observation. And that is that if mom receives interpartum prophylaxis and the baby goes on to develop early onset sepsis, the vast majority of those babies, as shown in the dark red here, will be ill appearing at birth. And it's very unusual for a baby who appears well at birth after interpartum prophylaxis in the mother to go on to develop clinical signs of sepsis thereafter. The problematic group in both of these slides are the babies who never become symptomatic. And in these bars are babies who were treated, had blood cultures done and were treated because of maternal risk factors. And we don't know whether the positive blood cultures were a benign transient bacteremia, or if those babies would have become symptomatic and would have been identified for treatment on that basis. So there is some remaining uncertainty about what trajectory these babies in this last category might have followed. But we can use the same kind of data to stratify in a different way. And I did this out of curiosity as testing the behavior of the pediatricians who are responsible for the care of these babies at our own institution. But we can use the same collections of babies. We had 277 cases where we could stratify the maximum interpartum temperature as greater or less than 38 degrees. And we could stratify the babies whether they were symptomatic or asymptomatic and look at their risk of early onset sepsis. And we can see that in the mothers who were afebrile, the risk of disease, even among symptomatic babies, was only about 6 per thousand, so pretty modest. If the babies were asymptomatic, it was extremely low. But if mom had a fever of greater than 38, the risk of symptomatic babies went to 45 per thousand. In the asymptomatic babies, it stayed at only 1 per thousand, very low in the absence of clinical symptoms. Of those cases, 169 allowed us to stratify in a more granular way, less than 38, greater than 38, greater than 38.5, or greater than 39 degrees centigrade. And we can see even at the high end of the spectrum here, among the symptomatic babies whose moms had high fevers, the attack rate was 591, or nearly 60% of those babies had culture-proven sepsis. So the message here is that if mom has a high fever and the baby is sick, you really have to worry about sepsis. That's really quite compelling. Same with a cutoff of 38.5. But if the baby is asymptomatic, the rate of sepsis is only 21 per thousand, or only about 2%. And I ran that number by our pediatricians and asked, so if you, at the point here, you would be treating 50 babies for every one who's infected. Would you guys consider treating infants who were asymptomatic, but whose moms had a temp above 39 degrees because of that risk? And uniformly, they said, no way would we do that. But what we might do is put that baby in the transitional care nursery for 12 to 24 hours and watch that baby a little bit more carefully. So that's adopting a midpoint strategy similar to the one recommended by the Kaiser risk calculator in a somewhat informal way. But with this data in hand, and as it was evolving actually, at Stanford, we asked the question of what would happen if we reserved treatment of babies who were asymptomatic only for the babies who were symptomatic and not for babies who were asymptomatic. And we found these 3 papers that reported experience with that, cohorts that were managed using serial physical examination. And in about 45,000 patients across these 3 studies, there were no cases of early onset sepsis among asymptomatic babies. All of the early onset cases were symptomatic. So on the basis of that information, we decided to adopt the policy of not using maternal risk factors as an indicator for evaluation and intervention, and that we would simply carefully monitor the babies with serial physical examinations. Now, we have the luxury of being able to do so because we have pediatricians who are in-house and assigned to the delivery room the transitional care nursery, and coverage of the well baby nursery 24 hours a day. So those people who were actually responsible for doing that work, Dr. Joshi, Gupta, Frymoyer, and others are the ones that are really responsible for the work that I'm about to tell you about now. Well, our first analysis focused on babies who were exposed to chorioamnionitis at or near term. And our policy, in accordance with the AAP guidelines, was that all exposed babies were treated with antibiotics. So our treatment rate in our baseline group was 100% chorioamnionitis exposure, got treatment. In phase 1, we moved these babies to just monitoring them in a level 2 nursery, but not treating unless they develop clinical signs. And in phase 2, we moved the serial examinations out to the maternity unit, where we taught our postpartum staff to do the serial observations themselves. The nurses learned the clinical findings that I'll talk about in just a moment. And we found that there was a further reduction in the treatment rate. So our overall treatment rate, shown here in the combined red and orange bars, went from 100% to 18% to 8%. And the treatment of initially well-appearing infants fell from 100% to 12% to 5%. We had only one early onset sepsis case among 649 exposures in those 2 phases of the implementation. That baby was identified because it began to show signs of clinical illness shortly after birth and was treated in a timely fashion and did well. If we look at the overall rate of antibiotic exposure in our babies greater than 35 weeks over this time frame, beginning with the baseline period in 2014, the serial examination protocol was introduced in March of 2015. We had an immediate marked reduction in the antibiotic exposure rate, which further improved the next year, was stable for a few years, then dropped in 2019, and has now stabilized at around 2.4% of our babies being exposed to antibiotics, down from a baseline of 11%. And the number of babies who were treated for every early onset sepsis cases that we are seeing fell from 300 to just 102. So this number is still larger than the target of 40 or less that we had set many years ago as we started this process of evolution. But it is high because the attack rate for early onset sepsis, because of the heroic efforts of our obstetrical colleagues, is so very low. Well, what are the clinical signs that are of interest that allow the physicians and the nursing staff in our postpartum unit to identify these babies who are sick? The first thing I would point out from this data, which is collected from 235 early onset sepsis cases across all gestational ages from the Neonatal Research Network, is that it's very unusual for a baby who has early onset sepsis to show no signs of clinical illness. More than 90% of the babies who have early onset sepsis are symptomatic in some way. The vast majority of them present with cardiovascular or respiratory findings, sustained tachycardia greater than a heart rate of 160, grunting, flaring, or retraction are traditional indicators of respiratory distress, sustained tachypnea, hypotension, which is difficult to use as a monitoring technique on the well baby floor, but cyanosis requiring supplemental oxygen, apnea or bradycardia, lethargy or poor feeding. So these are findings that are very easy for our nursing staff to learn to use. We've taught our postpartum nurses to do that. If they see any of these findings, they call, notify the pediatrician, and there's a physician evaluation that takes place. Those criteria have been formalized into these criteria by the group led by Alberto Berardi in Modena, Italy, where they've divided them into major and minor clinical criteria. And I won't belabor the point here, other than to point out that respiratory findings and poor skin perfusion or changes in general well-being, apnea, lethargy, poor feeding, and modeling of the skin things that are very easy to identify by a simple visual physical examination, don't really require careful counting of respiratory rate or heart rate, and certainly don't require any complex instrumentations. So these are the strategies that we have adopted at Stanford now. We do not use the sepsis risk calculator. If you find that introducing the sepsis risk calculator helps you in the transition to a new approach to ascertainment of early onset sepsis that includes a philosophy of careful vigilance for developing clinical signs of illness across your entire population of babies, by all means, I would encourage you to use that. But if you can do it and achieve a habit of careful examination of the babies that is universal and continues at least for the first 24 and preferably for the first 48 hours, then that is also an option number 3 under the AAP guidelines. So in summary, maternal risk factors, including chorioamnionitis, are very poor predictors of early onset neonatal sepsis. And that's true whether they're used categorically, as in the traditional process, or synthesized in a logistic regression prediction model, as in option number 2 in the new AAP guidelines. This poor performance is partly a consequence of the use of these risk factors as indications for interpartum antibiotic prophylaxis. So when the obstetricians see things like a high maternal fever, signs of chorioamnionitis, they give antibiotics, they reduce the risk for the babies, and it shouldn't be a puzzle to us why the finding is not predictive of bad outcome for babies. And actually, if you look at cases of early onset group B Streptococcus sepsis, most of the babies who are currently affected with that are being born to women who have negative prenatal screening for GBS colonization. Because if they had a positive screening, they would have received interpartum prophylaxis more than likely, and that event would have been prevented. Whatever strategy you use as your primary ascertainment tool, reliable recognition of early onset sepsis depends upon early and frequently repeated examinations of the babies, because 30% of the babies who are going to develop early onset sepsis are symptomatic at birth, but 70% are not. But 95% of those who go on to develop early onset sepsis and become symptomatic do so in the first 48 hours. So that has to be the period of focus for our careful observation of these babies on the well baby floor. I will close by just commenting that there is a paper that just came out in Hospital Pediatrics. The first author is Lisa Bain, B-A-I-N. She is one of the members of the faculty in my group at Stanford, and they describe in detail the process they used for introducing this kind of practice into one of our affiliated institutions, and I think is a very good roadmap for anybody who wants to emulate these practices in their own circumstance. So with that, I will stop sharing the screen and open up the stage for questions.
Thank you, Dr. Benitz, for your presentation. It's a good information for our practice clinic daily. So one of the questions, I'm gonna repeat it in Spanish, and you are gonna get the translation with Dr. Nuri. Mencionar algún comentario acerca de los reactantes de fase aguda en cuanto a PCR, procalcitonina y la velocidad de sedimentación globular.
¿A qué se refiere con comentario? Como si tiene alguna utilidad para poder abordar el riesgo para sepsis.
Y bueno, es una de las preguntas. Yo me imagino que acerca de la utilidad que tienen algunos en la detección de sepsis.
Okay. Doctor, one of the comments was, what would the utility be of using like PCR, procalcitonin, those kind of labs to try to see if the baby will have sepsis? Would you consider using those insights to implement on doing the diagnosis?
At this point in time, with the technologies that are available, the answer is no. As I said in that early slide, it's not really subject for the discussion, primary discussion today, but I'm happy to deal with the question. None of the current ancillary tests, including rapid PCR, as it's currently available, are sufficiently sensitive with a fast enough turnaround time to be useful for guiding the management of these babies. So it would be premature to adopt those at this point. What we have done at Stanford is we've decided not to treat babies unless they're symptomatic. And the place where those ancillary diagnostic tests, we hope, will influence our practice in the future is when we've got a baby who's symptomatic and we can't really tell whether it's evolving viral pneumonitis or progressive congestive heart failure or bacterial infection. If we had a rapid test that told us that the baby was not bacteremic or did not have activation of the innate immune system, we could decide not to start antibiotics on those babies and further reduce our antibiotic utilization. I think that there are some very interesting tests that are on the horizon. I saw a paper this morning looking at the use of neutrophil extracellular traps as a marker of bacterial infection. I think those kinds of signs of early activation of the innate immune system may be very valuable. I think some of the rapid PCR tools are almost ready for going into clinical trials, but have not yet been demonstrated. So I would hold that in reserve, but hope that those innovations are soon at our disposal.
But what about like C-reactive protein or procalcitonin?
Both of those, procalcitonin is a little bit faster than C-reactive protein, but both of those are elevated relatively late, 12 to 18 to 24 hours after the onset of bacterial infection. So they're not sensitive at the time of the initial evaluation. And their negative predictive value, if they're normal at the time that you're trying to decide whether to start antibiotics on a baby who appears ill, is not sufficient to allow you to not start antibiotics when you're worried about the baby.
Okay, so basically with both, even just like doing the PCR or these, it's not fast enough for the time needed that we need to make the diagnosis on the kid.
Right. Okay. Even if you can get the result back in very quickly, the biological response is too slow.
Okay, yeah, got it. I will go ahead and translate that now. Mencionó el doctor que con la tecnología que hay ahorita no es necesario. El problema con utilizar como la proteína C reactiva o la procalcitonina es que esto se eleva más tarde en la fisiopatología del bebé. Entonces, en el momento que realicemos la evaluación de este bebé para ver si tiene el problema o no, puede ser que salgan negativos, ¿no? Igual mencionaba el utilizar estudios como PCR, que no son lo suficientemente sensibles para poder guiarnos al manejo. ¿Cuál es la situación aquí? Que necesitamos saber el resultado ya. Entonces, no podemos esperar hasta tener los resultados de la PCR porque ya tenemos que ver cómo vamos a manejar al bebé. Ellos en Stanford, ¿qué es lo que hacen? No tratan a los bebés a menos que estén sintomáticos. Si es un bebé que está sintomático y que no ven mejoría, que no pueden saber si es viral, si es una neumonitis, si es viral, si es bacteriana, cuál es la causa, entonces esperarían a los resultados de la PCR.
Gracias, doctora Nuria. Thank you, Dr. Benitz. Another question for you. ¿Cuál ha sido la aceptación en las UCIN de Estados Unidos y en el mundo para el uso de las herramientas que se han demostrado desde hace unos 5 años que reducen drásticamente el uso indiscriminado de antibióticos sin elevar la morbimortalidad neonatal?
So what has been the acceptations in the different NICUs in the US and in the world? How easy or how difficult have they accepted the use of these tools that are demonstrating since 5 years ago that they reduce drastically the use of this antibiotics? And as you mentioned, we're just using them so much more than what's needed. without elevating the morbidity, the mortality in our neonates?
Yeah, I think that's an excellent question of how readily institutions are able to adopt these changes in practices. And I don't think any of you will disagree with me that as practitioners, we don't like change. So it's been a real challenge to get organizations and practitioners to move away from the old approach. And I think that's particularly true of people like me who are at the later end of our careers. You know, we grew up with a strong belief that any baby who was sick could be septic, and if a baby could be septic, they had to be on antibiotics. And if they're going to be on antibiotics, they had to have an LP. It's very difficult for us to abandon that set of beliefs. But I think it's important to recognize that the landscape has fundamentally changed. We're seeing only 1/10 as many cases of early onset sepsis now as we were 30 or 40 years ago. It's so much better for the babies. And we really have to focus our efforts on not giving treatment literally to hundreds of babies for that one baby who is infected, and focus our energies on identifying that baby when he or she gets sick. I think that's really the key component. Whether you use the Kaiser sepsis calculator as part of that strategy to help introduce change, or you skip over that as we have done at Stanford and others have successfully done. Votny and colleagues with Klaus Klingenberg in northern Norway have also reported success in this. So it can be done, but the change is not easy.
And you would say, like, in your ICU, I mean, yeah, like you mentioned, it's not easy, but it's doable. There's
Yes.
proof that it's working, and that the institution maybe slowly are improving and doing these changes.
Yes, the paper that I mentioned by Lisa Bain really talks about how they developed a multidisciplinary team-based approach to this. They provide a lot of detail about how they approach the change process at El Camino Hospital in Mountain View in California. I think it's a wonderful template for people to emulate. This cannot be a top-down thing where the chief of neonatology says, we're going to change our practice, and boom, it happens. That has to be something that involves all the members of the team, the physicians, not just pediatricians, but the obstetricians, and very importantly, the nursing staff in labor and delivery on the postpartum floor, and in whatever version of a well baby nursery you have. You've got to get everybody together on the team before you can introduce the change.
Okay. Bueno, el doctor comenta sobre la aceptación de la UCIN. Bueno, en la UCIN, que, bueno, como todos sabemos, ¿no? Al staff médico no le gusta hacer estos cambios. Entonces ha sido un desafío, un gran desafío conseguir que cambien del abordaje previo a este nuevo método, a estas nuevas herramientas, ya sea con la calculadora o como ellos en Stanford que deciden basándose en el examen físico del bebé. Sobre todo difícil para aquellos que como el doctor crecieron con esta cátedra de que si el bebé está enfermo necesita antibióticos, y si está enfermo y va a requerir antibióticos se necesita hacerle una punción lumbar. Es difícil hacerlos cambiar de esta doctrina con la cual ellos estudiaron por mucho tiempo, pero se ha visto que se acepta estas nuevas herramientas, porque se ha visto cómo ha disminuido el número de casos que se están tratando, el número de la población que se está tratando para aquellos que en realidad lo requieren, como ya presentó en las diapositivas anteriores, ¿no? Menciona que necesitamos enfocarnos a nivel multidisciplinario, no es solo llegar el jefe del servicio y decir, oigan, vamos a hacer ahora todo conforme a la calculadora, por decir, sino de que todos tienen que estar en el mismo, con la misma idea, no como cualquier otro equipo, donde enfermería, obstetricia, pediatría, todos están en la misma página tratando de enfocarse en lo mismo. Menciona nuevamente el artículo de Lisa Bain, un artículo que se realizó en el Hospital El Camino en California, que desglosa muy bien cómo si alguno de ustedes está interesado en llevar a cabo esta nueva herramienta, en cómo hacer que funcione en sus instituciones, en sus departamentos, en este artículo les explica bien cómo se puede llegar a este abordaje.
Gracias, doctora. Bueno, le damos la palabra a la doctora Samantha Moreno. Ella es residente de neonatología. Va a dar un comentario acerca de la plática.
Hi, good afternoon, and thank you for your excellent presentation. I would like to give you a question, if I may. What would you consider, given our specific population, this is feasible to reproduce here in our health system, given the lack of good birth control among our patients, or what would you be your considerations about this method of diagnosis of early onset sepsis, specifically in our